Hello everybody, my name is Jenny and welcome back to my YouTube channel. This is the second video of our series about methamphetamine and substance use disorder patients and practice considerations for anesthesia professionals. I want you all to know that methamphetamines are still unfortunately an issue in the United States. I know everybody's been thinking about COVID, so substance use disorder kind of gets put in the back of your head. But we are seeing an increase of substance use disorders, and this can be because of the stress that COVID-19 brings on, or social isolation. You know, if you're under a stay-at-home order, you can't see your support network, that kind of thing. Economic downturn, maybe you've lost your job, and then the social distancing, you're not able to see your network of people that helps when somebody is in remission from using these substances. It just makes it a little bit more difficult. So please, I want you to be aware, COVID-19 is a big deal in the United States, but unfortunately so is this. So hopefully you find this information pertinent. On to the pharmacology. Amphetamines, and really methamphetamines, were founded like way back in the day. They were used a lot in World War II, and you'll see that they're used in wars like speed, trying to keep soldiers, pilots, aviators, etc. awake and alert. Amphetamine is also used, various drugs as treatment modalities for like ADHD, so forth and so on. So what is it about methamphetamine that makes it so much more potent compared to amphetamine? It is this little methyl group right here. Our mechanism of action: once a person ingests methamphetamines, you have a dump of all these catecholamines, dopamine, norepinephrine, and serotonin. Not only that, but it inhibits monoamine oxidase, which means now you take away the thing that was clearing the catecholamines, so you have increased circulating catecholamines because you're not even having the thing that clears them away. It's kind of like a double whammy. Activation of pathways. You can see all the various ways that it activates the brain, but the thing that I want you to take away from this slide, when we have natural rewards like eating and sex, that increases dopamine dump to the brain about 150%. Cocaine is about 300%. Dopamine, on the other hand, from methamphetamine is 1,000 times more than our natural rewards. So it's a huge dump of these catecholamines. And what do you see? You'll see the tachycardia, bronchodilation, hyperthermia. Hyperthermia is not because of anything that happens in the brain. It's really more of a muscle activity. You can see psychosis, hallucinations. Sometimes people have seizures. A lot of cardiac repercussions from using methamphetamine. That has to do a lot with vasoconstriction as well, right? Sometimes if we have severe cardiac problems, you can get aortic dissection. And again, along the cardiac line, malignant arrhythmias, right heart failure, cardiac arrest, and death. This is not really the best substance that you want to use. Not that I'm advocating using any substances, but this one tends to be particularly dangerous, as I was saying, because of how much more catecholamine release you get from taking methamphetamine. Our pharmacokinetics: you can take this via smoking, oral, intramuscular, IV, nasal, and I have even heard about some people taking methamphetamines rectally or vaginally, though there's not a lot of data about onset, etc. for rectal or vaginal, but I do want people to be aware that that is another route of administration that people use methamphetamines. Onset is the fastest when smoked. Intranasal is the next, and then oral is 20 minutes. And then, of course, everybody's aware of meth mouth. Has a lot of damage to the teeth and gums, etc. So you'll see people with just rotting dentition. So as far as anesthesia is concerned, of course, you're going to want to be aware of any intubations, etc. distribution. So the thing that's interesting about this is that cocaine has the highest uptake of medication in the brain, whereas methamphetamine goes first to the kidney and lungs and then the brain. It has a prolonged clearance when compared to cocaine. So cocaine, and then please forgive me, my project was not about cocaine, so I can't speak with certainty on this. But cocaine is generally out of circulation for about an hour or so. I will follow up on that and post it in the comments. Don't worry. Methamphetamine is cleared via the cytochrome CYP2D6 pathway. You'll see about 4 to 7% excreted as amphetamine, and most of it is cleared within the first 20 hours, but this is highly dependent on urine pH. How do we detect methamphetamine? By blood or urine, and you can detect it either as methamphetamine or amphetamine. Urine is either going to show positive or negative. I've done a lot of digging on this subject. Like if you have somebody who uses alcohol and you can test their blood alcohol level, do we have anything like that for methamphetamine? No. And if I'm wrong, please leave me a message in the comments, because I have been searching for this information forever and I cannot find it. I would love that to be available, because then we could say, oh, they have XYZ level of methamphetamine in their urine, which means they will have this level of clinical correlation. We don't have that. So all we can say is, are they positive or are they negative? And the thing that's tough about this is that everybody has clearance that's different. So some people might pop positive for only 1 or 2 days, whereas another person might pop positive for 10 days. Now, does that mean that the person who has a positive amphetamine in their urine is going to experience clinical symptomatology? Another good question to ask. And if anybody has these answers, please comments. I would love to see it. Unfortunately, we don't have that. So at this time, and we'll cover this again a little bit later, if anybody is popping positive, we do recommend that they postpone their surgery just to be safe. And this is what we were talking about with the plasma half-life. Most of it's out within an hour. However, duration of action is about a day. And we've seen people who have used methamphetamine, taken methamphetamine, and then they're awake for 3 days. And then after 3 days, they crash, so forth and so on. But again, some people might have withdrawal for up to 10 days. And that's all dependent on how often and how frequently a patient uses too. So if you have somebody who uses daily versus somebody who uses occasionally, that's going to be different with how their body processes it. And I'm sorry to kind of leave you in this moment of, but that is the best that I can find from the literature at the moment. We will pause right here. Please, if anybody has any comments for me, leave them. I do my best to answer them. And if you have any more guidance, like, I do know where this magical article is, I would love to read it. Send it to me in the comments. See you guys again soon. We'll talk more about what anesthesia providers should use for methamphetamine substance use disorder patients who are having surgeries. Bye.